Hello, I'm Dr. Donald Jurivich, and today we're going to look at the question of age-friendly healthcare and the 4M of mobility. Just want to mention that I'm a professor of geriatrics at the University of North Dakota, and I'm program director of the HRSA-funded Dakota Geriatrics Workforce Enhancement Program. And I'd like to call your attention to the bottom here, which is the website where you can find this lecture and other presentations about geriatrics and age-friendly healthcare. So a pre-presentation question here, can you answer this? Which of the following factors increase the risk of falls in older adults? Is it opioids, chronic medical conditions, race, postural conditions, or all of the above? So please make your selection. And moving forward, we want to work on a couple of goals here. Firstly, we'd like to understand what happens with posture with aging, and we want to look at the epidemiology, why people fall, and we also want to look at the fall assessments, how do you analyze risk, and then ultimately we want to prescribe action plans for preventing falls. And this will lead to the fifth and last point here of addressing a mobility plan for older adults that have had a history of falls and those that have not yet fallen. So just to set it up, this graph shows the number of unintentional deaths related to falls in the 65 and older population. This comes from the Center for Disease Control, and while it's a little bit dated information from 2014, it shows a very, very impressive trend, which continues today, with 159% increase in fall rates occurring in the United States in just the last decade alone. If you happen to live in North or South Dakota, this area has one of the highest fall rates with injury in the country. And it turns out that some of our own assessments have found out that individuals, older adults from rural areas, have more fractures and head trauma than older adults from urban areas. So again, there's some health disparities there between urban and rural. And also want to point out that there are additional health disparities based on race, where Black men and women for each age group tend to have more falls. They also have more difficulty getting around, and so there's mobility limitations as seen in this graph here. And also this would be true for Native American populations. So there are some definite health disparities that we always need to keep in mind. So I'd like to have a case presentation here just to consider this whole process. And so we have an 82-year-old lady who's brought to the clinic by her daughter, who reports that when she was taking her mother over to the car, her mom just gradually fell to the ground and didn't have any complaints and just felt like her legs gave out under her. So with that type of history, how would you go and assess this older person? And she may or may not have reported this as a fall. And how would you assess somebody who, did not tell you that they had a fall, but still wanting to know whether they had a fall risk? And then if you do identify somebody as having a fall risk, what would be your action plan? So we firstly need to understand that with aging, as you can see by both this cartoon on the left, that the older adult starts to slump forward, the knees start to bend, and you can see this in the graph here with this lady, versus good posture on the right side here. But the important point is that you can see with this picture on the right that the plumb line from the ears down through the shoulders, down through the hips, and through the ankles bisects or goes straight down with good posture. Whereas if you drew that plumb line straight down on this lady, it would fall forward to her. So her momentum would be moving forward. So the postural changes are critical for aging considerations, and we'll also talk about flexibility and motor strength too as additional risk factors for falls. One of the big things that we don't always think about is what's called postural sway. And so it turns out that with age, the what we call the AP, or anterior posterior, both the front and backwards, as well as the side-to-side sway, increases with age. And for fallers, it increases even more. And people with memory loss or Alzheimer's disease, it increases yet even further. And so these are all conditions that are associated with increased postural sway. And this postural sway is made worse on what we call perturbed surfaces. So going from a hard floor to a soft surface like a rug or something with foam on it is going to create more postural sway. And those transition points are, or inflection points, are where a lot of the falls can occur. The other thing is this, sculpture shows is that when individuals have a perturbation in their balance, they just can't recover as fastly as we get older. And so if you even go from lying flat, supine, right, and go to a standing position, you'll still get a lot of postural sway within that moment. And so a lot of times you talk to older adults, and they'll tell you, I was getting up out of bed and I just fell right back, or I fell to the side, or I fell into the credenza next to the bed. But that can be without blood pressure changes, and or it could be with orthostatic blood pressure changes. So that's why we always want to consider in evaluating the older adult doing supine or lying down blood pressures and then standing up. I want to mention also that there is a newly understood relationship between physical and cognitive function. It used to be that, well, we thought that people who fell, they were just unstable or weak, separate from whatever was going on with the brain, whether it was, memory loss or memory intact. But now you can see at the bottom here, there's this crisscross where slow gait speed is associated with memory loss, and memory loss is associated with falls, and so they're interconnected, I think, is the key point. And in fact, people who move very slowly are at incredible risk for memory loss if they don't already have it. So in the process of evaluating falls, we want to consider whether it was a slip or a trip fall or an indeterminate fall. And your interventions are going to be a little bit different based upon the type of fall that occurred. So really getting a good history and understanding if the fall was not witnessed, to try to understand really what were the motions. The environment is really, really big. Were there slippery surfaces? Again, going from that hard surface to a soft surface, getting up out of bed, maybe even falling after several minutes after eating. A condition we call postprandial hypotension can be associated with falls. Oh boy, medications. Look at this. Everything just about causes falls, unfortunately. And we know that polypharmacy increases what we call the odds ratio. So that OR means odds ratio. So you got 1.3 times more chance of falling if you have 6 or more medications. Opioids and narcotics, pain medications all increase the risk of falls. Antipsychotics, those Haldols and the Risperidols, Geodone and any number of other antipsychotics massively increase the fall rate, and that's why we try to get rid of them. Sedatives also are terrible, and that includes the Z drugs, what we call Zolpidem for sleepers. And by the way, Zolpidem does not increase the quality of sleep, and it barely gets you 30 minutes of extra sleep. Antidepressants can also increase fall risk, and sometimes they're just a necessary evil because the older adult has depressive symptoms and needs to be treated. We also know that age-dependent diseases or chronic conditions increase falls. And so remember that case report of the older woman who went to the ground coming to the doctor's office. Well, that's called a drop attack and is often associated with heart failure. Sometimes chronic lung conditions can cause hypoxia on exertion, cause dizziness and falls. Frailty is a chronic condition that can be associated with weakness, fatigue, loss of strength, and slowness. Osteoarthritis can cause pain, which can in turn lead to postural instability and gait disturbances. So all of these things we need to consider with age and medical complexity as risks for falls. Falls are critical in our thinking because they result in injury and death. They're potentially avoidable. And we know that age impacts both the postural stability and our ability to fight back from a postural perturbation. And the neurosensory feedback is changed with age. And this all leads to our understanding of doing a complete and a systematic evaluation of both the fall risk and trying to look at the environment and also create a plan that will lower the risk of fall-related injury and death. You're not going to prevent 100% of all the falls, but for those that we do prevent, good. But for those that we don't prevent, hopefully we can prevent injury and death from those. So with that, I'd like you to answer this post-presentation question. Which of the following factors increase the risk of falls in older adults? Is it opioids, chronic medical conditions, race, postural changes, or all the above? And thank you for your attention.